Okay, so welcome to Unraveled Live. I don't even know what number live this is. I used to try to keep track
Well,
and say this is live number, whatever, but
I've
here we
stopped
are
too.
again.
Yeah.
And we're just happy for the people that can join us today. We realize Saturdays, especially during the summer, lots of people travel on the weekends. So we are grateful that anyone has joined us today. And as usual, just know that this conversation is not considered medical advice or medical guidance in any way. This does not establish a patient-doctor relationship in any way, even if you are patients of ours. This is not within the realms of a medical appointment, so should not be considered medical advice. So as long as we are all with that understanding, we can get started. So do you want to just start with the question in the chat
I,
box?
I I want to do a housekeeping
Oh, sorry.
statement first. Okay.
Oh,
So this will be posted on YouTube. This will go up today, right? As
yes.
opposed to what I've been doing. And just for those of you who might not know, as an update, I'm gradually posting all of the Patreon episodes we've done, which are over 100 hours. So it's taken me an insane amount of time. Um, and I'm working kind of backwards so that the oldest post will be coming up soon. I am putting the date as somebody requested for when that episode was recorded.
That's a
Um,
good idea, actually.
yeah, yeah. And so it's all there. It takes a lot of work or a lot of time. I really would request that people subscribe and like and do whatever it is so that we can get more people to watch, so that there's more reason for us to put this time in. Okay, we did this because there's 10 million people sick, and we have 1,800 subscribers, which is great. But where are the other 10 million people? So please help us out. Subscribe, share, send it to your friends. Thank you. My sales pitch. Now I feel like a YouTuber advertiser.
We want to be famous YouTubers. Not really, but we do. We enjoy what we're doing, and we love to educate and to spread information so that patients and doctors alike learn more about what we do and what we see and what we think and how we treat and so on. But if we're not getting, a wide range of an audience, then, the time that we put in, it sometimes becomes a little frustrating that
Right.
people aren't subscribing. So yes, we appreciate that, and hopefully it doesn't sound desperate, David. But
I don't mean it to sound desperate, except I do desperately want more people to watch.
yeah, I agree. Um, yes, so that's good housekeeping. And the other thing about the Patreon, just one last piece of housekeeping, is that we have to at some point shut down the page because they only allow you to halt billing for a month at a time. And I was traveling during the period when I needed to halt the billing. So I actually missed it by a day. And we got a couple of messages that people were charged. And so I was able to reverse a lot of those charges, but I have to remember every month to halt the billing. And so it would be nice if, David, I know that you spend a lot of time doing this, if we can get all of those videos out of there at least, so that we can just shut down that page and then we wouldn't have to worry about our previous subscribers getting billed. So we apologize for that confusion. Patreon is not the easiest to deal with or work with. So we're doing our best. Okay. So
Right.
let's just start. Let's start with the exosome question. I think
Yeah.
it's a good question.
So it's in the chat box.
That's the very first question.
Uh, Question about exosomes. Um, More about what that means clinically, I guess meaning what are exosomes about. From my research, sounds like exosomes are a general category, not a specific intervention. Excuse me. I would agree with that statement. It is not a specific intervention like giving a beta blocker. Exosomes are um, acellular vesicles that we have in our body. We all have them. Our body makes them constantly all day long. They are like signaling molecules and repair molecules. They can, not molecules, repair vessels. Think of it as a little spaceships that are running around in our body, and they seek out areas of inflammation, areas of injury. They release these signaling molecules to bring help, bring reinforcements, and they also have protein building molecules which help repair. Stem cells are filled with exosomes. And one can think of stem cells almost like a delivery system for exosomes. And then you can also purchase exosomes from laboratories and administer them intravenously. Um, it's a very simple procedure. It takes 3 to 5 minutes. I've not seen any side effects. The biggest problem is it's expensive and it is not FDA approved. There is no FDA indication for it, so most people are not doing it, right? And I've seen very, very good results with it. Eileen?
Yeah, no, I have as well. I mean, they have a lot of growth factors, which I think is important because it helps support the body's not only its own anti-inflammatory mechanisms, but regenerative mechanisms. It supports those processes which are often compromised with chronic disease. And so the exosomes can be very supportive. But as David said, they are expensive and it's not just a one and done kind of treatment. And usually you need several rounds of it to have any kind of sustained effect. So then it becomes very expensive. And of course, the FDA, that's the other big obstacle. So, when someone doesn't live in Seattle and they need to find someone who's willing to administer them, that's usually a barrier
Right.
because of the FDA, which is not uncommon with the FDA.
And I find about two-thirds of patients respond. And when I say respond, I mean going from unable to leave the house to bike riding and going out and doing everything they want to do, literally.
Yeah.
Um, Helps POTS, MCAS. It's pretty remarkable, actually.
Mhm. I agree. I've seen the same. It's usually not after the first. It's usually after sort of I would say three seems to
Right.
be
And
nice.
often it's this like bimodal and immediate and then a delayed response.
Right, exactly. And I do think with stem cells, when there is a fairly immediate response, I believe it's related to the exosomes that are also being delivered because they have a much more rapid onset of action as opposed to stem cells, which of course need the time to differentiate. So, um, but yeah, so it's a good question. All right, next question in the chat. What is the pathophysiology behind light sensitivity in severe ME/CFS? And how do you think about treating the symptom when nothing else helps? I love this question because I deal with this a lot. Um, I think about it a lot. I've done a lot of research on it a lot, and I have some very strong opinions that I've gotten some consensus with other neurology colleagues of mine with regards to what is behind this. So photosensitivity is a well-known um, uh, symptom of migraines, right? So a lot of patients who have chronic migraines have photosensitivity, and that's why people have to be in a dark room, but so do ME/CFS patients. And so there's a common denominator, I think, this is really a theory of mine, so don't hold me to it, but where there's just this like hyper excitability of the neuronal cells. And I see this even with those with visual disturbances, that there is not only cortical hyperexcitability, like of the occipital cortices, but retinal cell hyperexcitability. Um, and so and that's why I treat with some actually decent success with anti-seizure medications because those are designed, not that these are seizures, because they're not, but seizures are just another example of an electrical aberration of the brain cells, basically, to put it, I think, more simplistic than it technically is. But that's sort of how you can view it and how you can see it. And so anti-seizure medications, they are designed to, in some way, because they all work differently, there's different mechanisms of actions. There are quite a few anti-seizure medications actually available to us these days, and they all have different mechanisms of action, though there is some overlap, but they're meant to disrupt that electrical aberration, that hyperexcitability, that hyperreactivity of those brain cells that can ultimately cause a seizure. So that's why they can be very effective at decreasing the level of sensitivity to any external stimuli, frankly, not just light, but sound. I mean, a lot of my patients just can't even be in a room with lots of people talking, or they can't, some of them can't even have their kids in the room because any sound sort of triggers their symptoms, but certainly light. And as we know, David, a lot of our patients are lying in dark rooms with blinds, with eye shades on and earplugs in. And they have to even whisper. The sound of their own voice can actually be irritating sometimes, or just even the energy it takes to speak can cause PEM for some who are severely affected. So that's what the pathophysiology behind the photosensitivity is in ME/CFS patients. And I use anti-epileptics for those reasons. There are other things that, sometimes I refer to it as glutamate toxicity because glutamate can result in neuronal hyperexcitability. And so there are a lot of medications that are not technically anti-seizure meds that modulate glutamate release. And I've actually been using those more recently with success as well. And there's a whole list of those meds too. So it's also a glutamate toxicity, but ultimately it comes down to just this these neuronal cells are under duress, they're under stress, right? Because there's so much going on in the brain. There's so much, not only obviously mast cell release mediators, but other kinds of, the pressure disorders. It's like there's external pressure against the neuronal cells. So they're externally mechanically triggered. So there's just so much duress. And that results actually in what I've been referring to as a subhypoxic state. So the brain cells are just not getting enough oxygen, and that's another cause for their hyperreactivity because they don't have enough oxygen to basically function as they should. And so improving blood flow, improving blood perfusion, reducing the level of reactivity, those are my treatment regimens for patients with external stimuli integration disorder, which is sort of how I see it. A lot of kids have it as well, where they can't tolerate a lot of external stimuli. So we call it like sensory integration disorder is another name for it. So that's sort of how I see it and how I treat it. And again, a lot of patients do have reports of improvement of symptoms.
I,
So,
I would just add that in addition to all that, I think CCI and brainstem compression can often
oh yeah,
cause this, present with this, and one of the more dramatic examples of that is when a patient is doing home over-the-door traction or invasive traction with Dr. B. One of the things I hear over and over is suddenly my vision cleared. I could see better. There's a degree of clarity I haven't had. That's a little different from light sensitivity, but it's the same systems, and it's a quite striking report. And then another is mast cell activation, of course. Blame
yeah.
the mast cells. They have those thousand chemicals, and they do everything good and bad. And often getting control of that can help with light, sound, smell hypersensitivity.
Yeah, that's another point. So a lot of this is brainstem driven for sure. I mean, definitely. And I have learned recently in some patients that the blood drainage from the brainstem, specifically the midbrain, has really been problematic. And the midbrain drains ultimately into the vein of Galen, which then drains into the straight sinus. And we have been finding when you actually scrutinize some of the vessel imaging that you do on these patients, you can actually see where the vein of Galen and specifically the straight sinus is somewhat occluded or stenosed and compromised. And so the drainage is compromised from the midbrain, but as well as some of the other veins from the other parts of the brainstem. And that ultimately results for sure in a brainstem response, a brainstem reaction, which is usually not a good one. So and I was talking to Dr. Bolognese recently, and he was referring to sort of the brainstem jostling because it's not being, it can't drain well, so it becomes almost, you know, like engorged, and that's not really a right word because it's not technically engorged. It's just it can't function appropriately because of the drainage compromise, and so there's like jostling of it, and that also leads you into the connective tissue component of all of this, right? So we know that a lot of viruses will break down collagen. A lot of the mediators of the mast cells break down collagen. And so ultimately everything that's sort of meant to be held together in a certain fashion is not. So it just starts to fail. Did you want to say something? I saw you open.
I was trying to decide to say yes. Okay, well, so when you said jostling and what Paulo Bolognese was saying, it brought to mind another image, which may sound upsetting to hear, but I think this is part of what's going on in so many of our patients, including those that do not have full-fledged, need surgery CCI. The brainstem, you could describe this better than me, Eileen. It extends down from the base of the brain and turns into the spinal cord. And you can almost picture it crudely as it turns into a carrot, and that carrot is sitting in the foramen magnum, and it's just being jostled around. You're moving around. It shouldn't be there, that carrot. And every time it bangs into the side of the foramen and does this and does that, you're in a car and it bumps, you're going to get symptoms. It's going to do something. And as confusing as mast cell activation syndrome is in terms of symptoms and systemic symptoms, I think the jostling of the carrot is the same problem.
I agree. I agree. It's funny because the same morphometrics that we use for CCI, they were initially or originally designed for like trauma, like a motor vehicle accident or
Right.
a severe concussion, TBIs. And so when you think, so, that's why I think it's been so hard for so many, I don't know, different specialists to accept because these patients didn't have a clear physical trauma, right? So why are we interpreting these morphometrics? Because they're abnormal. And so while there hasn't been a history necessarily of physical trauma, there's been a history of what I refer to as neurotrauma, right? So these exposures create this widespread systemic neuroinflammation. And that is traumatic to the brain. I mean, neural tissue is very sensitive. And so any kind of compression, disruption, inflammation really just sort of sends it, functioning in a suboptimal way. I think we need a lot more research to get to the nitty-gritties of this, to look at the weeds of all of what I'm saying. It's a lot of like generalization, of course, and I want more specifics, but it really is how I see this and when I look at imaging, that's what I see. And
Right.
when I take the imaging and I then think about the patient and their symptoms and their history, it really does make a lot of sense. So I think we just need a lot more research in this area because as we go further, I mean, I just see more and more. And, as we always say, David, once you see it, you can't unsee it, right? So now every time I look at vessel imaging, it's just my eyes go right to all the different, the not only the dural venous sinuses, which ultimately get the drained blood from the different parts of the brain, but from the veins that actually take it there. Like you can see where there's a problem. And again, it's not like there's an occlusion where it's obvious on imaging and the radiologist will report, oh, clear stenosis, clear occlusion, clear clot, thrombosis. It's not that simple. And you have to look at many to sort of appreciate it. And I'm not even as good as, the vascular guys that do nothing but this, like Dr. Huey and Dr. Fargan and, those vascular surgeons or neurointerventionalists that do nothing but this. They see way more than I do, of course, as a non-interventionalist and a non-surgeon. So it's just so fascinating to me. And I get so frustrated sometimes that we don't know more and learn more and do more. But I'm gonna get off my soapbox now. Um, okay. All right. So I'm looking through a lot of discussion on kinase in patient forums. Do you have thoughts about using it for patients who seem to have blood clot issues? I have used it, and as
Yeah.
well as lumbrokinase. And I mean, I
Yeah,
think,
I think anyone who has blood clot issues should be on some of these products.
yeah, I agree. I mean, I think they're helpful. From what I understand, they really break down more of a biofilm than the clot itself.
Right.
And I think that's important because I think those clots sit in a biofilm. I think that's how they get stuck. So
Well, and likely the biofilm also is provoking more tendency to clotting.
right, exactly.
I use less kinase just because it's so much easier to get hold of lumbrokinase and
Yeah, I agree with that.
serrapeptase. Yeah.
Yeah, I do much more lumbrokinase, and I still do the blood clot testing. I think that's important, just to understand how much of a burden, and again, I think that I don't think you do the clot testing, right, David?
You mean Jordan Vaughan testing?
Yeah,
Yeah, no, I'm not doing it.
yeah,
I do all the other stuff we do, that you and
right.
I put together.
Um, so if the mechanism of long COVID includes a chronic tissue infection due to the fact that we have ACE2 receptors all over the body, couldn't an HCOV NL63 infection cause the same symptoms since it also binds ACE2? Could this be a potential viral cause of ME/CFS? Yeah. Yes.
I mean, I think the issue there, I mean, it's a good question and it's good biology and biochemistry. But at the end of the day, I think there are dozens of viral infections that can cause ME/CFS long COVID presentation. That's why some of the people are, some
Yeah.
people are changing the language to, post-infectious fatiguing illnesses,
Right.
which is a more accurate and hopefully more open to research name than chronic fatigue syndrome.
Right.
So it's an important point. It's good. I mean, the question is really good, and I think it drives home. You don't have to have ACE2 receptors or blockers or whatever to get sick from a viral infection. I've had patients with Zika and uh,
Hmm.
gastroenteritis and dengue. I mean, you name it. I've had patients with ending up with their final presentation of an ME/CFS defining illness.
Yeah, I agree. Plus, even, I mean, not only viral infections, but other
Yeah,
exposures. You
yeah.
even talked about in other past episodes, like drugs, medication, certain medications can actually cause an ME/CFS kind of picture.
Right.
Um, Follow-up question. Have you used CGRPs for light sensitivity and severe ME/CFS without migraines? Yes, I have. I have found, though, that the abortive ones, which are receptor antagonists, are not that helpful. The injection ones, which are the preventative ones, which are monoclonal antibodies, are helpful. And the most helpful is the new one, Vyepti, which is an IV infusion a CGRP monoclonal antibody, has been very effective for light sensitivity, even if you don't have an indication, a history of migraines. The problem is that without migraines, you have a hard time getting approved by insurance. So, which is always our obstacle. And I'm so sick of insurance companies. I can't even tell you. Yesterday, I just was like ready to like throw in the towel.
I'm not gonna.
I had to do a prior authorization, and instead of agreeing to a day and a time, they gave me 2 days that they'll just call me as
That's
if I
their
have nothing else to
that's
do.
their new game. That's the new game.
And they
And
didn't, by the way.
it's
They
usually on a
didn't.
Friday. Usually they
Yeah.
send out a notice on a Friday. If you don't
Yeah.
answer us in 12 hours,
Right.
it's
Exactly.
trashing
Yeah.
it. And they say, we'll call you. And of course they call in the middle of patient care. And
Yeah, that's
it's
exactly right. But they didn't even call me during the days that they said they would.
they
And
probably will say they tried.
yeah, oh yeah, but these days you can prove it that they didn't try. I have nothing on
They
my
don't
phone.
care. They don't care.
I'm sorry.
That's all right. RFK is going to fix it. Maha will fix all. Okay.
David.
Okay.
So anyway, so
I want to
Vyepti,
answer. Go ahead. I'm sorry.
no, I was just finishing my thought. So
Yeah.
Vyepti has been effective for those that I got it approved because they did have migraines, but I had one patient who paid out of pocket, didn't have migraines, couldn't get
80.
it.
80, could
And
you answer
it
this?
was effective, yeah.
It
Um,
looks like it's from Rodet.
what's that?
My cell phone's ringing. I'm asking you to answer it.
So is there any utility from the standard clinical clotting tests like PTT and et cetera? I mean, we do clot panels.
Yeah,
I think it shows
yeah.
risk of clot more than it shows presence of clots. So
Well, yes and no. I mean, I don't do I don't know what the name Jordan Vaughn's clot thing is, but I do, and you do, a pretty extensive panel, and the purpose of the panel is to assess uh, inherent risk for clots, meaning does the patient have a genetic risk factor, which many of us have, but it never matters. But if you have COVID or long COVID or ME or Bartonella, it might matter. And then looks for acquired markers that increase the risk. And then for other tests that show something's cooking, that there's evidence of clots occurring and the body trying to break it down. So that's a big, long test that creates a hassle and turmoil in the lab station, draw station, because I hate seeing all the tubes. But it is an important set of data, and it's amazing how much you learn from it.
yeah, I mean, and we say this all the time. I mean, we get accused of just doing too many labs, but you find out so much information about the patient, and oftentimes it leads you on paths of treatment options for the patient. And I think that that's what's so valuable. And if I don't have those labs, sometimes I don't really even understand the physiology of the patient. And I really need to sort of, look at a patient and sort of know what's going on internally. And the only way that I can visualize that is by seeing all their labs. So I do a lot of labs for those reasons, because then I get a real sense of what's going on physiologically in that patient. And I just try to explain that to them. Like I need to know, like, what's the physiology of David versus physiology of somebody else? It's all different. And like you said, there are inherent risks that we're born with. So
Right.
those kinds of things are
Mine's old. I have old physiology. Wise and aged. All right.
For a young 22-year-old who has had 10 years of neuroinflammation, starting with untreated PANS POTS, now ME/CFS. Fibromyalgia diagnosis, is there hope with the appropriate treatment that she will lead a normal life again? Perhaps getting rid of psych meds, fingers crossed. Does the blood-brain barrier disruption
All
heal?
right. I want to dive into this.
Go.
Okay. So the easy answer is what's been done for your untreated PANS POTS, PANS POTS. Um, I mean, my real answer is I think there's every reason to work, plan, and act as if you can regain a normal life. Otherwise,
What's
I
the
think this
point?
stands for Eileen. I wouldn't be doing this. right? And Eileen wouldn't be doing this, okay? We do not believe these are hopeless diseases and hopeless situations. That doesn't mean we can cure everybody. It doesn't mean that every ME/CFS patient will regain 100% of functionality. It absolutely means that many, many, many can get 80%, 90%, 95%. Um, and I think it's a matter of how hard your physicians and you, the patient, look and push to see if everything's been done. If you had PANS, did they check to see if you had tick-borne infections, or did they just treat for strep? If you had PANS, could you still have ongoing neuroinflammation? And is that being addressed in an ongoing way? You know, the problem, as everyone who's listening knows, there just aren't enough physicians who are thinking this way and open to pushing the envelope and stepping outside the box and going on to AI perplexity and Google and learning what they don't know so they can continue to take care of patients. And so it really depends a lot, unfortunately, on the patient being an advocate and bringing that stuff to the doctor.
Well said. Okay, a question re tick-borne infections. This is for you, David. So given severe ME/CFS, multiple tick bites in Africa over the years, unable to access sophisticated testing.
Thank you.
Oh, testing for tick-borne diseases, but no classic symptoms, a reluctance to start treatment unless absolutely necessary. So what are the clinical symptoms you believe would rule out tick-borne infection?
Let me
I don't
just,
think any clinical symptoms
yeah, okay,
rule it
it's a
out.
really good question because opens up a Pandora's box. Okay. Um, if I'm walking out in Cape Cod and I end up with a tick on my arm and I get home and within 24 hours I have 104 fever and shaking chills and a red rash or no red rash, obviously I have a tick-borne infection. Obviously I'm going to start taking doxycycline right away, plus minus maybe another antibiotic for 2 to 3 weeks, and 95% of the time I will be definitively cured and nothing to worry about. Deal done. Okay. What's what's important to understand, and mainstream does not understand it, is I could have gotten that same tick on my arm and not seen that tick or brushed it off or seen it and not get sick and therefore think, oh, lucky me, I didn't get sick. End of story. Flash forward 25 years, I get COVID, my immune system is completely screwed up, and guess what happens? Those tick-borne infections that I got 25 years ago reactivate exactly like EBV does. All right. And again, it's really sad and frustrating. Mainstream simply is not buying this argument. ID, infectious disease docs are not, but it's true. Okay. In that reactivated state, if it's in long COVID patient, which is where I'm seeing it all the time, or ME/CFS, I am not able to say to you, to the patient, oh, well, you have POTS and mass activation at SIBO and you photosensitivity. Of course, because you have Borrelia and Lyme disease. That's complete BS. There's no way I can say that. The flip side, which is even more frustrating for me, is, and if you'll take my 3 antibiotics for the next 4 months and be miserable and have nausea and vomiting and everything else, every symptom's going to go away. Because more likely, the symptoms aren't really going to change. Some might, but it's one of the real banes of my existence that I can't link the infection to the symptom. And it requires almost an act of faith on the part of the physician and the patient. And it is exactly the reason I will not treat anymore based on antibody testing. I want proof that there are bugs in your blood before I will subject you and me to the work of treating. That answer the question?
I think so. Let us know if it didn't. Um,
But it's a
okay.
great question. I
It's
hear
a
it.
really
It's
good
a question
question.
like people ask me all the time,
Yeah.
or I deliver the question if they haven't asked.
Yeah, I struggle with that often, with that question actually with my patients, but
Yeah.
obviously I don't know as much about tick-borne illness as you do, so I struggle with it often. In fact, that reminds me of a question that came through on the email, which is, does Lyme and co-infection cause autoimmune encephalitis? And if so, does treating Lyme and co-infections cure or improve autoimmune encephalitis? Or are these two separate issues that needs its own treatment? What's the test and treatment for autoimmune encephalitis?
It's
I mean,
in,
it does
it's in
cause
the email
autoimmune
you said.
encephalitis. This was one of the
Yeah,
emails.
I'm just looking for it.
Oh,
So the question is, can tick-borne cause encephalitis? Is that what the
yeah,
question is?
it does. I mean,
Yeah, I mean, it certainly can. I mean, even mainstream will acknowledge that. And I've had patients with neuroborreliosis,
mhm,
neurologic Lyme disease. It's not something you miss. It's dramatic. I mean, I've had patients come in with a full-on facial, and you take the history, and it's obvious what's going on, and they get 100% better because
yeah,
it's an acute infection. I think that the take-home point here, there's a vast difference between acute tick-borne disease and late-stage chronic tick-borne disease. And that's where the world kind of breaks into two camps, okay? Um, we all know how to take care of acute disease, and we can get it better, and most people will get better. It's the other group. The I guess I'll throw in on the acute. I'll use myself as a model. So I'm on Cape Cod, and I got that infection with Borrelia, and I gave myself doxycycline. Well, maybe I also got Babesia and Bartonella and didn't know it,
right.
right? And that won't touch those two bugs, and they may still reactivate next COVID infection, next COVID pandemic. Um, so yes, it definitely can cause encephalitis.
I've seen it. I mean, I've tested on CSF. I've tested for Borrelia and have found it. So I know for a fact it can affect the central nervous system and
Right.
cause an encephalopathy. So encephalitis is more of an acute inflammation of the brain. When it's chronic, it becomes become encephalopathic. Um,
Yeah, that's what I want. Yeah, good.
right.
That was I didn't I want to we should amplify that. So the acute might be an infection, actual organisms in the old little brain. Um, Encephalopathy presenting later is really more like a PANS-like illness, which is neuroinflammation caused by tick-borne infections. You
Yeah.
might not find bugs in your brain if you do a spinal tap, but you have all the clinical and characteristics of a PANS or PANDAS-like patient, including getting better if you treat the infection.
Right. And plus you can also, but you can find markers of hypoxia, basically.
Right.
I mean, I regularly, and I don't always do it in CSF, but I very regularly in blood will test for certain things that are known to be consistent with lack of oxygen, like specifically neuron-specific enolase, is one, neurofilament light chain is another. Those are markers of neuroinflammation, of neuro damage, of hypoxia. And so I regularly see them being elevated. So I think that that's important. And yes, and if I were to do a lumbar puncture on those patients, I don't always find bugs. In fact, I usually don't. It's not a common finding, but I very commonly will find evidence of some level of inflammation for sure. And then sometimes I find even catecholamine disruption. So in terms of balances of the serotonin and dopamine and such, you can even find, changes of normal ratios of those neurotransmitters specifically. Okay.
So there's a chat question, and it's also in the email, same person. So, do you find DAO supplementation helpful? Um, yes, I do. It varies by the patient. So DAO is an enzyme that we have or supposed to have in our gut, help metabolize histamine from food. Um, there's only one lab in the country that can measure it. It's a lot easier to just say, why don't you try DAO and see if it helps?
Right.
Okay. Um, and I want to emphasize that DAO is treating histamine intolerance, meaning the enzyme is lacking. So when you have food with histamine, it might cause a problem. That is not the same thing as mast cell activation syndrome, which are your endogenous intrinsic mast cells that are unhappy and exploding. Different problem. But yes, I think it's always worth a try.
So do I. So for
Uh,
people who have tried H1, H2 blockers, singular cromolyn, quercetin, what would be the next treatment to try? Ketotifen LDN did not seem to be effective, but previously have been on Adderall, but caused sleep issues and worsening energy crashes. Not a candidate for Xolair because of pre-existing Addison's disease. I've been told maybe time to try medications like imatinib, and I'm hoping there is something else.
Um, so I have a few questions back to the person. So when you say have tried H1, H2 singular, Montelukast, cromolyn, and quercetin. If you're implying they didn't work, the obvious next question is, well, what doses did you use?
Right.
If you tell me, well, I took cromolyn, that disgusting liquid, 4 times a day, 1 vial, you might as well not take it. That's like turning on the faucet and letting it drip. You need doses. You need to dose up if there's no side effects. And I have patients taking 800 milligrams 4 times a day, 8 of those vials 4 times a day. If they need more, we go higher. Same with Singulair. If you take it once a day and it's helping, twice a day is better. So my first point would be dosing. Okay, don't assume that there is a right dose, and absolutely don't assume that what it says on the box of the bottle is correct. I don't think any doctor Eileen and I work with ever use H1, H2 blockers at the bottle indicated dose. We are always using double, triple, and quadruple. Um, why is Xolair contraindicated in Addison's? Eileen, do you know that? I don't know
I
that.
don't know that.
Okay. Um, and then other medicines. So I wouldn't be reluctant to try imatinib. Yeah, it's scary because it's a quote chemotherapy drug. It's remarkably well tolerated with minimal problems. The biggest problem is it doesn't usually work as well as we want it to.
Yeah, exactly. That's what I was
It's
going to say.
very
I
frustrating.
haven't had a lot of success with it.
Right. Same with hydroxyurea, which is another chemo drug. When these two work, they're fantastic, but
I
they
agree.
just, all right.
I have one patient with bone pain that was completely gone with
Right.
hydroxyurea.
I have one exactly like that. Yeah. I would add to this list, although this will get us into a whole nother area, of course. This is the kind of person, if they've really been through all these drugs and been on adequate doses, I would have a zero threshold, low threshold to start microdosing of tirzepatide.
Mhm. Oh yeah, definitely. Yeah, I mean, I can't get over how well tirzepatide is working for so many of my patients.
I know, it's incredible.
Yeah, I know
Incredible.
it's pretty amazing.
Yeah.
Yeah, I just got a message last night from a patient who is like so thrilled beyond belief with her response to it. I do want to say one thing about just sort of this, and as we talk about all the time with mast cell activation syndrome, yes, it's very common to feel like a drug that has been started is not working, that you're not tolerating it, you feel worse on it, symptoms are flared, and we very quickly just think that it's related to the mast cell activity. But when you do a deep dive into the mechanisms of actions of these drugs that we prescribe, there is some sense to, oh, Monica, she's going to answer your question. I just want to finish my thought. There is some, thought to be given to the idea that when you give a drug, when it goes to its target and starts to do its magic, its mechanism, there is it can sometimes flare things up appropriately, right? Because it's actually working where it needs to work, where a receptor or an enzyme or mediator is going chaotic and going haywire. So it's actually doing its job. And for that brief period of time, while it starts to integrated into the body's physiology, you could feel worse. So I've recently started to just tell patients like, if those symptoms are not a deal breaker, can we just stay on this drug for a couple of days and just see how you feel? And more times than not, they'll say, okay, and then I find that those symptoms tend to
Yeah.
calm down and they tolerate the drug a lot better. And so when you think about the physiology and the mechanism of action, it does sort of make sense that it could first have an initial seemingly adverse effect, but then over time it gets better. I mean, acetazolamide is a perfect example. You get those paresthesias that go away if you continue on the drug, right? So, and only I would say like I can count on one hand the number of times that a patient said to me, I just can't stand these paresthesias of my
Yeah.
hands and my face, and I just need to stop it. And I go, okay, then let's stop it. But
Yeah.
I do think that there's something to be said for like, let's just sort of give it the old college try. And if you don't mind sort of just tolerating these symptoms for a few days, let's just sort of see how you do.
Yeah, I really want to underline and bold that. Over and over, I have patients come to me, new patient come to me, and there'll be a list of these are the drugs I tried. These are the
Right.
ones that I can't take. They don't work. I It's not that I don't believe the patient. It's it's mostly that I don't believe that the drugs were properly managed, okay? Whether they were properly tapered or whether the dose was pushed enough or whether the patient was coached on how to work through the side effects. And it's a really important situation because if the patient says, well, look, I took all these, I can't take them, you've thrown
Mhm.
out half the tool arsenal.
Right.
It's really a problem, and it's important to understand most of these drugs can be taken if they're done carefully and properly. That's not to say there won't be side effects, but as Larry Afrin always says, if you had a reaction to uh, Benadryl, okay, or you're not reacting to the Benadryl, to the diphenhydramine molecule. It's that other crap that's in the pill.
Right, the excipients.
All
Yeah.
right. And that's another piece that you need to sort through. So it sometimes leads to conflict between doctor and patient, because I'm saying, well, please give it a try. Please give this drug a try.
Right.
So it's important. I just want to emphasize it. Thank you, Eileen.
No, no, thank you. Monica, you wanted to answer some of David's questions.
Educate me.
Yes. Thank you so very much for even doing this on a Saturday for all of us. I was going to mention, just as you did, trying and erroring through the H1H2 blockers has been really important. I found Zyrtec does help. I take it twice a day now. Hydroxyzine helps me better than Benadryl, so I take that 3 times a day. So I'm on like the 6 to 7 doses of those to keep them no more than 8 is what my specialist has said. And I guess my question with all of that is, how many things do we keep adding to know which is the most effective? Or is it just the trial and error of things and that's just how it goes?
You
Yeah.
know, um, again, I'll use Larry Afrin. Larry will often say, we're on this listserv, and people ask a question, and Larry will give an answer that is literally this long. Okay, it's probably 5,000
Seven
words.
paragraphs.
It
Yeah.
drives me insane. Okay, but he's very smart, and this buried in those words is a lot of important stuff. And one of the most important things is, for you, Zyrtec and hydroxyzine will work, but for me, it might not do a thing. And for Eileen, coffee might stabilize her mast cells, and we just don't know. It's different for each person. So I admire what you and your physician have done in terms of trying and seeing what works. But if you still have symptoms, then you go on and you keep adding. Frankly, it's unfortunately can be a growing list, but that's the only way we can do it. It is entirely trial and error. All right.
And the last question with the Xolair, I was told it had to do with serum sickness, that I could develop serum sickness. I don't know what that means exactly, but for whatever reason, the Xolair would counteract or interact with my Addison's, and I'm not sure what that means even.
Yeah, I have no idea. I mean, it's a monoclonal antibody, so it certainly
Yeah.
can cause an allergic reaction.
Right, but I mean, anything can.
Right,
Mm.
in anyone, and a little bit more likely in an MCAS patient. So there is a degree of increased risk. But as long as if you have Addison's, which means adrenal insufficiency, and therefore you wouldn't be
Oh,
sitting here talking to me if you weren't fully replaced, you should have no additional risk that I can understand.
right. Exactly. Well, that's exactly right. I guess if it was untreated Addison's, right, wouldn't it mask the
Yeah, well, then you'd have
symptoms?
a problem.
Mm. Okay.
Yeah,
But I'm assuming you were treated for your Addison's.
Yes, I'm on hydrocortisone for
yeah,
that
So,
and many other things for
yeah,
mast cell, EDS,
right.
POTS, all the things.
So,
interesting.
okay.
But I will look it up because now I have to know. So
Thank
Yeah.
you.
I'll go to my Perplexity, my new go-to book.
AI.
Yeah, it's great.
Yeah, I
It's
know.
incredible.
Um,
Okay. Um,
okay, so let's go to some of the YouTube questions because we're
oh,
gonna get
YouTube. Okay.
nasty
Yeah.
emails that we ignored the YouTube questions.
All right. Let's go over there.
We only have 10 minutes or so left. Um,
Whoa, 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 whoa. Sorry.
what happened?
I clicked on a different YouTube.
Oh. What is your opinion on the use of low-dose nicotine patches that some in the long COVID ME/CFS community have been experimenting with to help with the symptoms? Oh, I like this question. Nicotine patches I've used a million times in my career. We used to use them for Parkinson's disease before Big Pharma gave us all kinds of drugs to use. But I really like them actually. And I can't say that it's been magical for my long COVID ME/CFS patients, but I would say about 20% of them have improvement of symptoms. So the nicotine, it's what it does is it interacts with the nicotinic acetylcholine receptors, which are actually in the brainstem. So speaking of the brainstem again, it helps to release dopamine. It also helps to minimize some of the symptoms of long COVID ME/CFS. Some of the fatigue is improved, though that's not a prominent symptom to respond, but any kind of certainly like brain fog definitely improves. Muscle spasms definitely improve. So, and dopamine, of course, is part of our reward circuitry. So I would say that even like mood, and that I think it's part of the brain fog experience, but mood certainly improves. And along with that comes motivation, so I think that then there's motivation to sort of try the next thing because sort of maybe as we were just saying with Monica, this is a lot of trial and error, which can be very frustrating for the patients, but it's also frustrating for us. And I just had this conversation with a patient yesterday. Like at some point I decide, okay, we've tried like a million meds. Like how much longer are we going to just do trial and error for these meds? So then I just start using some of more, aggressive, like bigger guns kind of things, like immunotherapies and those kinds of stuff. But I do think that the nicotine patches are certainly worth a try. What's nice about them, they're just patches and you could just take them off if they don't
Right.
work for you.
You
And
don't
they
even
have
need a
very
doctor
few
for
side
them.
effects.
You don't need a prescription, which is nice. You don't have to argue with your doctor.
Right. I think you do need a prescription for the prescription strength.
Really? I thought the 7 milligram you just buy. Oh, I don't know. Maybe I'm wrong.
Uh,
I
I've
have
been
not had much
prescribing
luck with
them.
it.
I
Yeah.
know that would be curious to me if they're now over the counter because I've been prescribing them. But anyway, I think then they get covered by insurance that way.
Yeah.
Um,
Um, I haven't had much luck with them. I love the biochemistry, the reason they're supposed to work. I
yeah.
mean, that paper was great, but I don't find it. I have not had great luck with it.
Like I said, about 20% of my patients have improvement of symptoms. None of them have been cured, of course. So I don't think it's like the panacea that we hope it to be.
So there's another YouTube question. When you're treating individual symptoms, is there often one that is driving the others? I am in the UK trying to get investigated for all septads, so hoping one thing may be causing the majority of the symptoms. So this is a really important question, or maybe I'm biased because I have very strong feelings about this question. So if we have a septad patient, let's keep it simple. They have POTS, mast cell activation syndrome, SIBO with leaky gut, um, and an infection. Okay, I'm gonna put connective tissue on the side because I can't really do anything about that in the beginning. Okay, I believe major.
Oh, you froze, David. David, you're frozen.
Still frozen?
Oh, yeah. No, there you are.
Okay. Um,
I didn't know what your thought was. Otherwise, I would have finished it for you.
all right.
No, go.
Yeah, so I was trying to say, so if you have these problems, okay, it is my opinion, based on what I see and everything else, that the major driver of the symptoms of ME/CFS and long COVID, the things that check the boxes in the criteria for ME/CFS, are primarily in the beginning POTS with hypoperfusion. You can't live well if you don't have oxygen in your brain and your muscles, and SIBO with leaky gut causing further inflammation, further increased mast cell reactivity, and then, of course, mast cell activation itself. And so I will go after those three things first. Those are the so-called low-hanging fruit. And frankly, they're relatively easy to treat. We can do something about that. I can do something in the first visit. All right. And and once we get control of those, that patient often will feel better and able to then move on to the more complicated stuff. Conversely, I will never start treatment for tick-borne infection until I've tried to control those things.
Right.
I just think that's, it should be almost like a rule.
Yeah.
Um, and in terms of the other thing I think this person's asking, all of those things I just described make each other worse. So every time you fix mast cell, you are going to help your POTS. Every time you treat that leaky gut, you're going to help your mast cell. So it's really an important concept that you go after the long hanging fruit, which is making the person sicker, and also the fruit is banging into each other. Pushing this too far, this image. Okay.
But I agree with you. I think that the autonomic dysregulation should be addressed first and foremost because most of the symptoms are an autonomic response. And usually that response is inappropriate or
Right.
disproportionate. And so to fix the autonomic dysregulation first and foremost, I personally think is key to the rest of the recovery plan. Because if you don't get that sympathetic state settled, where there's an appropriate response, then everything we do, the autonomic nervous system is just going to go
Right.
haywire.
Right.
So you have to really calm it down. And if you want to call it POTS, because again, that is the easiest thing to treat, then that's fine too. And then you can
But
start.
you're right, Eileen. I thank you for saying autonomic. I should have used that word because that is the key piece here. And if for those of you that follow the literature in long COVID, over and over and over now, every new paper is saying, oh, it's the autonomic nervous system, baby. It is the autonomic nervous system that's being, disastrously zapped by COVID and driving this
Yep,
illness forward.
yep, absolutely. Okay. What do you know what chikungunya virus is?
It's a nice little virus from South America and the Caribbean. And I've had two patients with ME/CFS as a result. What was the question though? Let's see. Chickamauga.
Well, there was original question was, do viruses cause macular edema? And then particularly asking about chikungunya virus.
Yeah. I'm not really sure the answer to that. Certainly wouldn't surprise me, but I don't know the answer.
Yeah,
I've never treated an acute case of that virus. I've just seen the
right.
downstream results.
Okay. Is quercetin helpful daily for brain fog energy? I say no.
Yeah, I haven't seen great stuff with it. I use it. I suggest it.
Yeah.
It does help with mast cell stabilization.
I find IV form of quercetin to be way more effective than the supplemental form, the oral supplemental form.
Luteolin, which is another plant flavonoid, does have possibly more brain fog benefit effects.
I had EBV April 2020. In May 2021, diagnosed with post-viral fatigue syndrome. My PCP does help with symptoms with medications, but I'm bedridden 75% now. Not sure if my age is added to my issues. I'll be 63 next month. With all the info on the internet, what would you recommend for me to share with my PCP? I would, again, I would recommend seeing our episode on the septad because we always refer to that as a roadmap. And the intent of that is to sort of guide PCPs on the different diagnoses that there are treatments for, as you've already said, David. So there's treatment for each diagnosis of the septad. So that's why we consider it a roadmap. And it's really, for those who are PCPs who are seeing these patients, I think it's invaluable, frankly. I think it's a really great place to start and to start with treatment recommendations for the patient.
So this is the EBV mono question, April
Yeah.
2020.
hmm
I'm assuming, but I shouldn't, but I'm assuming that this person had EBV mono because of COVID, or was this, I would ask that question. And if it hasn't been asked, somebody should ask it for the patient. All
Yeah,
right. Um,
that's true. April 2020, that was
yeah. So, and
COVID.
because that leads to EBV reactivation upwards of 80% of patients.
Yep.
And I would look into the use of antivirals if EBV is still active based on a PCR or an early antigen. Age has nothing to do with it as far as I'm concerned, but I'm very biased. Um, and with all the info, yeah, hey, if your PCP is open-minded, just ask him or her to watch some of the episodes. It's not that we're geniuses, but that's why we have this out there to teach.
Right, exactly. And it's just because we've been doing this for so long. And I really do think that our septat, the way we lay it out, is like I keep calling it a roadmap because it's just such a great word for it, because
Yeah,
it really does guide you on where to start and then where to go to next. And several of the treatments for one helps to minimize the symptoms of another diagnosis of the septat. So,
exactly, because it's all interacting.
mhm. So another question from the YouTube page is ELISpot infection testing reliable? I really like ELISpot. I mean, it's been used um, in different scenarios. but and it looks at some of the cytokines, I know. So that this one specifically asks about interferon gamma and IL-2 response. So, I've said this before about cytokines. I know that there's some specifics with regards to particular cytokines and chemokines about what will prompt their release. But I also will add that I think that they're somewhat, I don't think they're that specific. I don't think they're specific enough for us to make reliable interpretations on the elevations of one versus another. I mean, the interferon gamma, of course, just comes from T cells, recruits macrophages, but that's what our immune system does, right? So I think that it's hard to just reliably say, oh, you clearly have this infection or this diagnosis because of this cytokine elevation. I
I
just
have the same problem. I
leading.
completely agree.
Yeah,
Completely agree with you. It's too, um, it's trying to take something and make more of it than it really is.
right.
The cytokines are our body's way of surviving and managing attack and managing recovery. And just because you see IL-54 doesn't mean you must have Borrelia. That just doesn't work for me.
Right. And I guess one last question we'll take because we really are out of time, but from the YouTube page, that seems like a quick question for you to answer, David. Can you share the doses of your SIBO protocol so this person can share with their doctor for the Xifaxan dose for hydrogen producing bacteria and lovastatin dose and metronidazole dose for methane?
Yeah, I saw that question. It was asking an awful lot of things.
Oh, okay. Oh, there's more.
Um,
Okay, sorry. Oh, yeah, you're
yeah,
right. I
yeah.
have to
I
read
felt a
more.
little uncomfortable actually answering
Okay.
it,
Yeah, I
because that
agree.
we're moving into the prescribing and we have to be cautious on that.
I agree.
We have addressed most, as Eileen, I think you said, we have addressed a lot of that in the
Patreon.
in the other Patreon episodes. Um, I mean, I'm fine saying standard doses Ifaxan 550 3 times a day.
That's all I thought it was asking. Yeah, I
Yeah,
think it has to read more.
and lovastatin, the dose I use is 20 milligrams once a day for 2 months. But understand that dose is something I literally just made up based on reading the literature. There is no
Right.
trial data to give you the right dose, and most physicians don't use lovastatin. I still mostly get patients coming in on flagyl and neomycin as the second drug. So it's a yeah, I'll stop there.
Okay. Chronic fatigue caused by iron deficiency. I mean, yeah, iron is necessary for red blood cells. Red blood cells are, of course, carry the oxygen. So if you don't have enough red blood cells because you don't have enough iron, you could definitely be fatigued. It certainly can contribute. I don't think it causes what we know as ME/CFS, but I think it certainly doesn't make it any better. And it's true that an iron infusion, you don't immediately feel better. It takes a while for the iron to be incorporated to produce more red blood cells. People always think that there's going to be some magical, acute, immediate response to any intervention, but you have to I always say respect the physiology of the body. Things take time. They take time to be incorporated. You need sometimes transcription and translation, and you need more proteins and enzymes to be, transcribed. And so it can take a little bit of time before you feel the absolute effects of some intervention. And then, so when you give iron, it takes a little bit of time for the bone marrow to incorporate them and to make more red blood cells. And then once you have more oxygen carrying capacity by the additional red blood cells, then more tissues get their oxygen and there's less fatigue. So yes, I think that iron deficiency doesn't cause ME/CFS, but it does contribute to the level of fatigue.
Yeah, I want to just say two things. One, real caution, chronic fatigue, as you just said, is not ME/CFS, and that would be a pretty significant mistake if somebody's telling you you have ME/CFS because of iron deficiency. The other question that somebody should be asking is, why do you have iron deficiency? Needing IV iron to treat iron deficiency is not like taking 2 Tylenol in the morning for a headache or for a stomach ache or something. That's a very significant intervention, getting intravenous iron.
Okay.
And I think it's imperative that there be an effort to find out why that person is iron deficient. And that would be true for ME/CFS patients or for any person, me, Dr. Ruhoy, and everybody on this list, okay? Just my old internal medicine hat being put on for a second.
I love that hat.
Okay,
All right, we are done. Thank you for
great.
all of your questions and for being subscribers, and we appreciate and are grateful for you. And like David said at the beginning, please share and tell everyone that you know to subscribe. and we will continue to do the work that we're doing.
Yeah, these were great
Labor of
questions
love.
today.
Yeah.
Great
So,
questions.
very good questions, actually. Yeah,
Yeah.
this was enjoyable. I like answering questions. So, all right, guys. Well, have a great rest of your weekend, and we will see you soon.
Okay. Thank you.
Bye.
Bye.